Hey everyone, today's video is about the basics of non-invasive vascular surgery testing. So the type of tests that you would get when your history and physical have given you some hints that peripheral arterial disease might be an issue for your patient, and you want to get that next level of testing to confirm and partially localize the diagnosis. This is very important, not only for anyone on vascular surgery, but really anyone taking care of old sick patients, as peripheral arterial disease is very common. And understanding these beginning tests can help you get the workup started out efficiently and on the right foot. So, what we'll be talking about today in this video is, first of all, just the basics. What are these various tests? What do the acronyms stand for? And then how are they each interpreted? We'll also focus on the limitations of each test because this really helps you know when you should order them in practice and how the different strengths and weaknesses of each test tell you which test you should get at which time. And then finally, here at the bottom, I just have a list of some of the basic tests that we'll be talking about today: ABIs, TBIs, PVRs, duplexes, etc. So first, zooming back out to the big picture, these tests are primarily looking for arterial insufficiency as opposed to venous. And then, what clues would you get from your H&P that makes you think that you should get some of these tests? So, of course, pulse exam is kind of the obvious one. Anyone with a diminished pulse exam or maybe only signals as opposed to pulses, claudication or pain with walking. And then these two at the bottom I highlighted because these are kind of pathognomonic for arterial insufficiency of the lower extremity, and that is rest pain and tissue loss. Of course, people have pain in their legs for various reasons. This type of ischemic vascular rest pain is often described as a burning pain in the balls or toes of the foot. I think about that as kind of being the most distal location of the leg. That's the hardest place for blood flow to get to. And that pain should be constant. It gets worse at night when the legs are elevated and improves with bringing them down. Then, when we talk about tissue loss, of course, people get ulcers for various reasons. In this case, tissue loss due to arterial insufficiency is usually kind of pinpoint ulcers at the very tips of the toes. Again, I think about that as being the farthest place for blood to have to reach. You can contrast this with ulcers at the medial malleolus, which are classically venous ulcers, or the typical diabetic foot ulcers, which tend to be at bony prominences. So once we have some clues from the H&P and we've decided to look further into our tests, what sort of studies do we get? So the first study, really the workhorse study of peripheral arterial disease, is called the ABI. ABI just stands for ankle brachial index. And it's calculated by taking blood pressures in both feet and blood pressures in both arms. And you calculate one for the right and one for the left foot. So the one for the right ABI is going to be the highest pressure in the right foot. And we say it like that because you usually measure it twice, once in the DP and once in the PT artery. And then the highest pressure of both arms. So this is the brachial blood pressure, right? It all kind of makes sense with the name, ankle brachial index. And then you interpret that value. Of course, you do the same thing for the left foot as well. And so when you get these values, there's just a few numbers to remember. So 0.5, 0.9, 1.3, and those are really the three numbers. So when we talk about a normal range, usually somewhere between 1.9 and 1.3 is normal. You do not have peripheral arterial disease. Somewhere between zero point 0.5 and zero point 0.9, you have moderate disease, and less than 0.5 this way, you have severe arterial disease. And this makes sense, right? If you go back and you remember that it's the foot pressure over the brachial pressure, the less blood flow you have to the foot, the lower the pressure is going to be on the top of this equation. So the smaller this value is going to get, assuming that the arm pressure stays the same. And of course, remember, zero point 0.9 is normal. If the foot and the brachial pressures are the same, that's essential normal blood flow to both limbs. The reason you have to remember 1.3 is once you get above 1.3, this is caused by non-compressible vessels, and you can't actually interpret an ABI that's too high. So remember, we got the sweet spot, 0.9 to 0.3. Less than 0.5, you have really severe disease. Somewhere between 0.5 to 0.9 is moderate. And then greater than 1.3, you just can't interpret this test, and you're going to have to get additional testing to help you figure out what's going on. So speaking of those additional testings, we have TBIs and WBIs. We'll knock out WBIs first. Those are just wrist brachial indices. Those are typically done to look at upper extremity arterial disease, which is actually much less common than lower extremity. The only reason I can really think of that we get that commonly is situations with, for example, Steele syndrome related to various dialysis access and fistula types. But that's not going to be something you see very commonly. Much more common is the toe brachial index. And this is exactly the same as the ABI or the ankle brachial index, but instead of the bottom blood pressure cuff being on the ankle, it's actually a small little cuff on the toes. And so why do we do that? Well, the toe vessels are, for whatever reason, less affected by calcification, which is the reason calcification is the reason that vessels become non-compressible. So if you have a non-compressible ABI, sometimes the toe brachial index is a better measure that can tell you if there's arterial disease present or not. So at least according to UpToDate, a normal TBI is greater than zero point 0.7. And again, the reason you'd use this is if your ABI is not giving you enough data because of non-compressibility. All right, another very common test is the PVR. This stands for pulse volume recording. This is, again, really good, just like the TBIs for identifying disease in these stiff, non-compressible vessels, but it gives you the added bonus of giving you a sense of the level of the lesion. So how is this test done? So if we have someone's legs here, supposed to be a long leg and a foot. Uh, Maybe I'll redraw that actually. So someone's legs here. So we got thigh and calf. Frequently, you put a blood pressure cuff maybe around the high thigh and the low thigh, another one at the calf, another one at the ankle. Then you inflate each of these cuffs. You usually do that on both legs, but I'm not going to draw both. You inflate each of these cuffs to a certain pressure, and then they're very sensitive cuffs to actually changes in the volume of the leg. So the leg, you can imagine, swells slightly as blood flows into it, and then compresses back down to kind of its normal size. And so these cuffs are so sensitive, they actually measure that subtle change in volume of the leg based on blood flow through it. What's nice is that does not depend on vessel compression to get a measurement. So this can be used if your ABIs are non-compressible. And because you have a measurement at each cuff, you can really see like, oh, if this waveform's good, this waveform's good, but this waveform's not, there's probably some issue up here in the vasculature and gives you a general sense of the level of the lesion. It's a little bit tough to just show you one picture of these waveforms to get you to understand the interpretation because they look slightly different depending on which vessel you're looking at, whether it's the arms or the legs. So a good rule of thumb that I use for interpreting these waveforms is sharp and tall equals good. So something like this would be a good PVR. And then as it gets worse, it might look something more like this. And, when it becomes kind of this flat line, that's really bad, really severe arterial disease. So with a PVR, sharper and taller is good blood flow, wider and flatter means poor blood flow. All right, continuing on down the list. I promise we're going to put all these together into a more comprehensive system later, but right now we just really need to get our basic vocabulary down. So next we're talking about duplex ultrasounds. First of all, what does duplex mean? Well, duplex actually means that there's two forms of ultrasound being used in these studies. One is B mode or brightness mode. That's actually just that normal grayscale image that probably pops to your head when you think about ultrasound. And then Doppler is related to flow measurement, traditionally with waveforms, but also can be with color. So similar to the last study, you get these done at various levels along the leg, so it can give you some information about localizing the lesion. And it also is related to waveform interpretation. So good blood flow is a multiphasic waveform, worse is biphasic, and the worst blood flow is just monophasic. So what that might look like, multiphasic goes up, comes down below baseline, and comes up again before going to the next beat, right? So this is one beat on this side, another beat on this side, right? So you can see it has multi phases of flow this way, this way, assuming a baseline, something like right there. Biphasic blood flow looks like a wave like this. So you see it doesn't cross below and go back in the other direction. Then finally, monophasic is essentially just a worse looking biphasic, where it's flatter and wider. So again, just like before, you can see different levels along the leg. And if you see good multiphasic waveforms here and here. Maybe if this is a leg, right, you have a good waveform here, good waveform here. And then all of a sudden you get monophasic or biphasic waveforms here. You're suspicious of a disease at that specific level. All right, we're almost getting to the end here. So TCPO2s, this is kind of a unique study. That's why I put it at the end. It's a little bit different than the other studies in that it measures less how much blood flow there is and more about it's about oxygen tension and really wound healing potential. So TCPO2 stands for transcutaneous oxygen pressure, and it's used to evaluate the potential for wound healing. If you remember a single number here, I'd remember 40 and 30. Greater than 40 is usually considered to have good wound healing potential, and greater than 30 is equivocal but possible, and less than that, you're really unlikely to heal the wound at that level. So this is often used, for example, if you have somebody with a non-healing wound, they need an amputation. Um, First of all, it helps you decide if they truly do need an amputation or if that wound will heal. And it gives you a sense of, okay, if I go up and maybe do a BKA, will the wound at the BKA site heal or not? So it's really good for planning amputations and dealing with chronic wounds, which is, of course, a common thing for vascular surgery. All right. So all those tests were really about initial diagnosis, kind of adjuncts to the history and physical looking for arterial disease. But once you know your patient has arterial disease, what do you do next? Do you just take them to the OR based on those tests? Usually not. You usually need a little bit more granular test to give you an exact sense of where and what disease is present and how you plan your treatment. This has become even more important as endovascular surgery has come into its own, as it's really the characteristics of the lesion you see on some of these more advanced tests will give you a sense of whether or not this is best treated from an open or endovascular approach. So these advanced tests that are used once you have a diagnosis to then go ahead and plan your intervention are CTAs or CT angiographies, MRAs, MR angiography, or a DSA or digital subtraction angiography. So, of course, a CTA is essentially just a CT scan. This is probably the workhorse number one study for this situation. It's easy to order, it's available at most centers, it's very reproducible. MRAs are usually ordered when people don't want CTAs for whatever reason. Most typically, it's when somebody has chronic kidney disease, which is, of course, very common in these patient populations, and you're worried about the dye load causing some contrast nephropathy. Then finally, DSA, this is just kind of traditional, think of it as angiography like you would do in the cath lab or in the operating room. So the advantage of DSA is that it is diagnostic and potentially therapeutic. It can also sometimes have lower dye loads than a CT. But of course, this one is the most invasive of the procedures because it involves actually sticking the arteries, kind of essentially starting an endovascular type of case just to image the vessels. All right. So we've talked about a lot of stuff, and if you need to, go back, rewind, review those tests until you get a sense of them in your head. But I just wanted to give a few quick clinical scenarios and give you the most common test ordered in that scenario to help you get a sense of how these might be used in practice. So first, the first line test for peripheral arterial disease. Hopefully you're thinking about ABIs, right? So these are the workhorse, the first line test. If you're on vascular consults, this is what you're usually telling the consulting services to order. The caveat here is that usually ABIs are not just ABIs when you order them. If you did it yourself at the bedside, it might be just an ABI, but most centers order for ABIs does a couple of tests all at once to compensate for some of those weaknesses with ABIs we talked about earlier. So, for example, most of the institutions I've been at, when you order a quote ABI, you actually get not only an ABI, but also Doppler measurements at multiple levels throughout the leg. So remember, we talked about those Doppler waveforms, as well as PVR measurements throughout the leg. And again, we talked about PVRs and those waveforms. So if your ABI gave you all the info, that's great. But if not, and maybe because the vessels are not compressible, then you could go and look at the PVRs, right, which don't require compressible vessels. And then Doppler and PVR will often give useful information in synchrony that you might not get you doing each of them on their own. So first line test ABIs, but really it's probably a combination of some of these non-invasive tests. All right. So you have a patient with known vascular disease, and you want to know they have a wound. A lot of times you may have done an endovascular procedure to open up that vascular disease. You got it as good as it's going to get, and you know what the ABI is, but you really just want to know, will this wound heal, or are we going to have to do an amputation? So the answer here is going to be those TCPO2s. This is really their only use, is assessing wound healing capability. All right, and then last scenario, which study are you going to use for preoperative planning once you know a patient has vascular disease and they have symptoms that requires a surgical intervention? This is going to be your CTA, most commonly, of course. Again, if contrast allergy or issues with kidney disease, it might be an MRA. And if you have a pretty good sense of what's going on and you think you're going to manage it endovascularly, maybe you'd start with a DSA with just traditional angiography so you can diagnose and treat at the same time. But most of the time, it's going to be a CTA in this situation. All right, so that about covers it. Hopefully, now you have a good sense of what the basics of non invasive vascular testing are, and you can navigate your way through that sometimes complicated alphabet soup to order the right tests and interpret it well for your patient. These videos are for educational purposes only. Do not use them to diagnose or treat any diseases. This is not clinical advice, and we will see you next time.